pretty sure. Yeah. Just let's stop talking about yoga pants.
Is that going to be on the test?
Nope. And if you ever meet my wife in any of you guys' ceremonies or anything like that, your husband says you're awesome. What's that? All right. So I think that this seems like it should be higher, but maybe it's just because it's emergencies, actual emergencies. I mean, if you went into the gastrointestinal calls that you get a year in this nation, it'd be like billions, right? But of the emergencies, most of them are bleeding. You guys ever gotten those calls where you've got somebody that's bleeding and they're bleeding a lot and they won't stop bleeding and they're pale and ashen, and yeah, those are terrible. Because you can't really do anything about it. And the same thing with us. So we get those patients and we have to figure out where they're bleeding from first before I can call anybody in for surgery. And yeah, those ones they suck. So gastrointestinal tract. The way I like to think about it, anything in the GI tract is in the donut hole. No pun intended. Your body is the donut, and your GI tract is the donut hole. So from your mouth to your anus, it's going through the hole, and the GI tract isn't necessarily, I mean, it's open, it's exposed, right? So it's not, I mean, obviously it's still part of our anatomy, it's still part of our body, but this is where all the absorption and transfer of everything is back and forth. So if you can kind of compartmentalize and think about it that way, it helps you understand as we're going through the GI tract how everything's happening. Is it in the donut or is it in the donut hole, right? All right. So digestion, breakdown of large food products. There's mechanical digestion. There's chemical digestion. As you would assume, mechanical digestion is mostly upper GI. This is mostly mastication. You get a little bit of turning in, even the esophagus, but mostly in the stomach, in the pylorus. You get some mechanical digestion, as it's just kind of pushing and moving food around. Obviously, chewing, you're physically breaking down the food. And then you got your chemical digestion, that's your enzymes, right? Breaking it down into the different proteins and things that you can actually absorb and whatnot. Saliva is certainly part of that process. Food enters the mouth, you got chewing, saliva is involved with it. Saliva production happens when you smell the food before you ever put the food in your mouth. Chew up the food, you cover it in the saliva, help lubricate it so you can swallow it down. That's your food bolus, right? As soon as you swallow it, that becomes the food bolus. When it enters the stomach, that food is then turned chyme. And we'll talk about that here in a little bit. But so your starch breakdown starts with your saliva and chewing. The action of actually moving food through the esophagus and through the intestines is called peristalsis. That kind of contract, uncontract, moving food through. So in the stomach, you've got hydrochloric acid and pepsin, and those are the two main chemicals that your body produces to help break down food products in the stomach, at least kind of start that whole process before the enzymes come into play. They're made by separate cells in the stomach. Hydrochloric acid obviously is why your stomach is so acidic. That's why we have peptic ulcers, gastric ulcers, all of that. So these two can damage your stomach wall. So what does the body do? It secretes a mucus that helps coat the stomach lining, helps coat your intestines. so that you don't get damage to that wall. Medications that we take can prevent the production or the ability of your body to make that protective barrier, that mucous membrane, and then your own stomach acids start to create an ulcer and lead to bleeding and various other things. So this liquid, this food bolus, when into the stomach, it becomes this. That's what it's called, it's chyme. When chyme is fully digested into the blood, 95% of the nutrients are reabsorbed, or I should say not reabsorbed, are absorbed in the small intestine, going from the small intestine into your bloodstream. So going from the donut hole into the donut, right? Water and minerals, that's mainly reabsorbed into the blood in the large intestine, and there your pH is even lower. And then of course your large intestine, that's where everything left over kind of hangs out until you're ready to get it out. So usually your GI emergencies are from underlying pathological process. Sometimes they are self-induced by patients, as we know.
Is GERD self-induced?
It depends. It can be and it can't be. So there's certain things that you can do, like alcohol consumption and excessive smoking, that are going to cause you to have GERD. And then there's certain things that you can't help, like tumors, like Zollinger-Ellison syndrome. These are things where you have overproduction of acid or underproduction of the mucous membranes, or whatever things that patients can't control. And then there's other factors that go into GERD and the creation of gastritis and peptic ulcers, gastric ulcers, and things like that. Other than this, just stress in general. People that are physically stressed, meaning they're sick a lot. Cancer patients is one that comes to mind, that have a significant propensity to get GI ulcers. But people that are just hospitalized, that's why we prophylactically treat every patient admitted to the hospital with GI protectant medications, usually a PPI or an H2 blocker like Pepsi. So, and that's because just the stress of being sick and the stress of being in the hospital can create ulcers, can break down that mucous membrane, or I should say cause your body to produce less of that protective layer. Because if you guys can think of which part of the central nervous system would be responsible for creating the mucus barrier of your stomach lining, your parasympathetic. So if you're consistently stressed, either emotionally or physically stressed, which part is in overdrive? Your sympathetic, right? So your parasympathetic is being inhibited, and you're not only sometimes creating more acid, but also decreasing your body's ability to protect against the acid. So smoking, alcohol, stress, obviously any kind of caustic substance that people swallow, and then poor bowel habits. And there's a lot of different, examples of that, but that mostly is for things like hemorrhoids and things like that, because the hemorrhoids can be very self-induced. If you're on the toilet for longer than 5 minutes, then you should just call it quits and get off, because people that are consistently staying on the toilet trying to crap for longer than 5 minutes, like I said, consistently, have a tendency to develop hemorrhoids. Creating a time where you have increased pressure on your rectum causes dilation of the veins, leads to hemorrhoids. That's why women get hemorrhoids when they're giving birth, because just the pressure and the force of what they're doing and holding all of that weight pushing down for so long. So, hallmark of acute abdominal pain goes into 3 classifications: visceral, somatic, and referred. So, what do you think visceral pain is coming from? What's that?
The lining. The organs.
Opposite. So, visceral is organs, right? So, this is pain coming from organs inside. Where do you think you feel visceral pain? Visceral abdominal pain. Does it depend on which organ? Actually not. With generalized, if it starts and it's pure visceral abdominal pain, your organs don't have great nerve endings. They don't have great sensory function going back to your brain, telling you exactly where that's coming from. So if it's localized or limited to the organ itself, it feels like generalized abdominal pain. Where does your pain hurt? It hurts right here, and they point right to the middle. So oftentimes an umbilicus. And then when that process gets worse and you get inflammation that starts to affect the peritoneum and the lining of the abdomen and some of the surrounding tissue, then it becomes localized, right? So appendicitis starts here, and then over the next 12 hours, it gradually moved down here, and now it feels right here. And that's because the inflammation is getting worse, and now it's becoming more localized. And that's what somatic is.
Is there any pain receptors in the tissues, the connective tissues between your intestines? I don't know what that's called.
Yeah.
Those tissues have receptors.
Yeah, those tissues have receptors. More of your really, more sensitive, localized pain receptors are going to be in your peritoneal cavity, that lining. All right, the peritoneum. And then you've got the referred pain. As you can guess, referred pain is organ pain that's also kind of connected to some of the other, sensory nerve groups that affect other parts of the body. So if your gallbladder is inflamed, and it's inflamed enough that it's irritating your diaphragm, you're going to feel it in your shoulder because of the phrenic nerve from the diaphragm coming up and the way that the sensory nerves go back to your brain. You're going to feel it in your shoulder. There's a lot of different examples of that, of referred pain. All right. So visceral pain, this is organs. And when we're talking about hollow organs, mostly we're talking about gallbladder and appendix. You can understand what a hollow organ would be, right? There's space, or I don't know, you can't really say empty space, but there's not organ tissue in the middle. It's a hollow. And then you've got your solid organs, your kidney, your liver. You can certainly get visceral pain from the visceral peritoneum, meaning that capsule over the organ itself, but don't confuse that with the somatic pain from the overall peritoneum of the abdominal cavity. All right?
Does the appendix do anything specifically?
Appendix has no function that we know.
It's just that little thing that's there.
So, what causes the pain? It's the inflammation, the distension, and then ischemia. We'll talk about the different ischemic pathologies. So, pain, obviously, in varying intensities, characteristics. That's the whole PQR, or I should say OPQRST thing. So we're transmitting that signal. You've got afferent neural fibers going to the spinal cord, telling your brain where they think that pain is coming from. And if it's visceral, like I said, that can be vague in the beginning. So your hollow organs and gallbladder, appendix is two common and good examples of that. Often give you that visceral pain first. And then as that pathology gets worse, then you get that somatic pain and more localized pain. So somatic pain is that sharp, localized pain that can come from bacterial chemical irritations of the abdomen. That's why you're obviously going to have a lot of somatic pain if you get rupture of gallbladder or rupture of appendix and you've got bacteria into your abdominal cavity and space, and that irritation is going to cause a lot of localized pain. And the degree of pain obviously is dependent on how bad that rupture is, the spread of that irritant. Referred pain, we talked about this a little bit already, but so originates from a region other than where it's felt, right? These are another. This is another example: the dissecting abdominal aortic artery. You get pain between the shoulder blades. You get that back pain. That's in referred pain is often makes, as you can imagine, abdominal pain and diagnosing abdominal pain difficult because they could be getting referred pain, or they could be having pain locally from that area where you think might be referred pain. But this kind of gives you an example of different elements of referred pain. And here in the back. So as you can see, pancreatitis causes pain just about everywhere. You get pancreatitis here too. Here you can get pancreatitis as well. It causes pain everywhere pretty much. So that one can be often difficult to figure out unless you've got a good history and the patient is truthful. So in assessing the abdomen, it can be certainly similar to the trauma assessment, where you want a good history and you want a very detailed physical exam. Standard precautions, survey the scene. This is going to be very important for you, something that we'll never be able to get in the hospital. If you guys aren't able to get this information, then we just never know about it. But when you're going to pick up a patient, surveying the scene, seeing if you have any causes, medication bottles, alcohol containers, ashtrays, buckets, emesis or sputum, all of the above. If you can give us any of that information, it's certainly extremely helpful. And of course, mechanism of injury. Trying to figure out, is this abdominal pain trauma or medical? Which, like with severe pancreatitis, and pancreatitis actually has a very high mortality, so you have to take it pretty seriously, but you can get specific bruising with pancreatitis, which I think to the layperson would be assumed as trauma, where you'll get a lot of flank ecchymosis, very pronounced bruising in your flanks, called Gray Turner sign, or colon sign is where you get kind of that periumbilical bruising. So you'll sometimes doctors, paramedics, whatever, will assume that the patient's lying and chalk it up to trauma when it's actually pancreatitis. But this is just going through the different functions and doing your primary assessment and a good physical exam. So palpate pulse, check skin color. Anytime you have a complaint of GI bleeding, you need to find out if this is something that's truly emergent and you need to act quickly or not. Because even those black tarry stools, oftentimes patients won't call in until like the 6th black tarry stool or whatever, especially the elderly. Some patients will call in if they think that they might have had a fleck of, something that looked different. They study their stool like ridiculously, but other people, like an old farmer, will come in after like his 10th black tarry stool and they're already on death's door. So you have to be astute of how that patient looks and how quickly we need to act. So obviously, if it's life-threatening, treat it appropriately. Secondary assessment, your sample history, make sure that your physical exam and your history is adequate. So the OPQRST, and then I like how they added the ASPN, as if that wasn't already long enough. And now insurance companies are forcing us in our dictations to go through specifically and hit on each point so that it can be easily identifiable to the insurance company that we hit every aspect of that AP, QRST, and ASPN for billing purposes. If we don't hit every aspect of that, the insurance might not cover it at all. So, O for onset. This is obviously very important in your diagnosis, figuring out when exactly it happened. Is this a gradual onset? Was it an acute onset? Helps us understand what's the underlying pathology. Provocation, what makes it worse, what makes it better. This is a good example. Walking relieves the pain. It's usually GI or urinary. If the patient draws their legs up to their chest or side, that can be very evident of peritoneal inflammation. And when they actually lay down on the gurney and you get anywhere near their abdomen, they flex. That's rigidity. That's usually a telltale sign of a surgical abdomen. And sometimes if they have bad enough rigidity, we won't even get a CT scan. We'll call the surgeon. Patient needs to go to the OR. We're not going to wait for the CT scan over the next couple of hours. And that can be enough if you've got a good physical exam. So the quality of the pain, is it tearing pain? Is it dull pain? Is it sharp pain? All indicative of different kinds of pathology. The region of the pain, trying to figure out if this is referred or if this is localized, if this is visceral, if this is somatic. And you can figure out where it originates. The severity, self-explanatory, the time, estimation of the pain's time of onset. Is it coming and going? Is it consistent? In general, any abdominal pain that's constant over 6 hours is considered surgical until proven otherwise. Are there associated symptoms? Color, smell of the vomit or the stool? What does it look like? Is it black? Is it red?
Can I back there on that 6 hour pain window or whatever?
Yeah.
How much of a priority is that patient when they come to the ER then? Is that something you guys move on really quick?
Yeah, it is. They get the initial triage, they get the initial vital signs, and we usually jump on lab testing and everything else fairly quickly to get the patient started. If every bed is full, obviously we can't put them in anywhere, but they get evaluated emergently and get everything started on them.
So it's more exploratory, or open them up if they're saying that they have pain here. You don't have to see.
Yeah, if they have a rigid abdomen,
it's something there.
and yeah, then a rigid abdomen is peritoneal inflammation, which means that something in the abdomen has gotten bad enough that it's irritating the peritoneum, and this is going to require surgery regardless. So yeah, they'll do an exploratory. Oftentimes, even with a rigid abdomen, because sometimes with a rigid abdomen you can't localize, but even with a rigid abdomen you can localize and figure out where it's at. You don't need a CT scan. You can, if you know it's appendicitis before, why wait for a CT scan if you already know what it is, right?
So is that how you would qualify their 6 hours of pain? I mean, there's got to be a severity marker. They just say, I've got the stomach ache for 6 hours.
Right. Well, is that pain coming and going? Is it consistently getting worse? What kind of pain is it? So yeah, it's not just like any abdominal pain. It's not nausea. Some people will call nausea pain. So it's you kind of have to tease out, but I mean you usually know fairly quickly if it's serious or not, right? But yeah, you can go through and figure out your severity. But in general, as a general rule, consistent constant abdominal pain for greater than 6 hours is surgical and has to be treated as such until you prove that it's not. All right. So, and then the added on the back of this OPQRST is the associated symptoms. So the bowel morphology, bleeding associated with it, and so on and so forth. Acute abdomen patients usually are not wanting to eat. Most abdominal pain patients, if it's legit, or don't want to eat or drink anything, right? So those patients that come in with abdominal pain that hasn't gone away for a day, as soon as they come in, they're asking for a sandwich and chocolate milk, whatever. Like, really?
We're talking about the house.
What do you mean I have to wait until after the CT scan? This is ridiculous. But what's that?
Talking about the house of charity.
So, and this is another reason why some of those, female abdominal pain is worse than male abdominal pain because you've got all of the, it's different. It's more difficult to diagnose as well because you've got the added ovaries and uterus that can certainly cause different problems. Is that a torsed ovary, or is that appendicitis, or is that a simple cyst, or is you get a lot of different symptoms from, or a lot of different diagnoses from pain in the same location. All right, so last, oral intake is obviously going to be very important in figuring out can this patient even get surgery. If it's truly emergent, then it doesn't really matter. But for the most part, an anesthesiologist is going to be weary and refuse to take the patient to the OR if they ate a burger, an hour before or whatever. Gastrointestinal emergencies that can cause chest pain, reflux, ulcers, gallbladder disease, all cause chest pain as well. So you get your medical history, you complete your physical exam, general appearance, posture of the patient. If a patient has a rough time and as you're taking them to the hospital, they complain about every bump and every movement of the ambulance, that's usually peritoneal as well. Sometimes I'll go into a patient's room that the nurse is like, I think that this patient's full of crap or something like that, and I'll accidentally bump the bed before I even start talking to the patient. And if that vibration and that bump freaks them out, then I know I need to take this a little bit more seriously. If they're just, it doesn't bother them at all, or they don't even realize that it happened, then I feel like I can really take more time and get a better physical exam and history and figure out if this is legit or not. All right. So, complete physical exam. Oh, I should say, auscultation is important, but for the most part, 90% of the time, it's worthless. There's really two things where auscultation is going to be important. One, bowel obstruction. If you don't have any bowel sounds and you're really truly listening for 30 seconds in each quadrant, you've got no bowel sounds, pretty indicative of a bowel obstruction. And two, if you've got a bruit, right? So if you've got a hernia and you've got an aneurysm. All right, so extension of the abdomen, usually not a great sign. You've got free air build up in the abdomen. That's a bad sign. Fluid loss, so this is what I was talking about before, this periumbilical ecchymosis, colon sign, or ecchymosis in the flank, Gray-Turner sign. Those are both indicative of severe pancreatitis and usually have a very high mortality when you start seeing that kind of pathology. So palpating the abdomen is obviously very important. Defines the area, and you can really tease out hopefully where the abdominal pain is coming from.
Dr. Reedy?
Yeah.
Do you have any tricks then, maybe in the trade? Some of our patients can be quite large, as we were talking about this morning.
Mm-hmm.
And it can be a little tough, maybe.
To get a good exam?
Yeah, to get a good, I'm not trying to be mean. I mean, seriously, I mean, they have, they're 300-400 pounds
Right.
complaining of abdominal pain.
Right.
I mean,
That's absolutely true.
Where do I start?
And that's difficult for anybody. I mean, truly emergent abdominal pain is still going to have that rigidity-like effect, meaning palpating anywhere is going to cause them to, it's more difficult to assess rigidity on an obese person, but you can still do it because even though you might not be able to feel that tightening, they still do the same thing, right? And then, I mean, sometimes you have to push harder with obese patients, and they hate it. And oftentimes, if I think patients are full of crap or there's guesswork into whether or not this is legit or not, because abdominal pain is faked all the time, right? I use my stethoscope. I'll act like I'm oscillating the abdomen, and I'll be pushing down with the stethoscope in the different quadrants, and they won't react at all. And I'll be like some patients, like you'll like mash down with your stethoscope, nothing. Like touch them with my hand, So, and then I just document the crap out of that. I don't get CT scans on those patients, waste of resources and whatnot. But some patients can be difficult, and you can get tricked the other way. Crazy people can get sick too, right? So even though a patient's crazy and ridiculous, they might still be super sick. So some of these patients are difficult. So you really have to treat every patient like they're telling you the truth. And then as you're going through your history and physical exam, trying to tease out what actually is going on and what's not. So abdominal pain, your abdominal pains need a large bore IV, right? Especially if you have any inkling of worry about the severity of their abdominal pain. Masking of the abdominal pain is obviously difficult pre-hospital because they have significant abdominal pain. You want to give them analgesics. I would suggest fentanyl so that when they get to the hospital and the doc does his exam, it's not the patient's not snowed with morphine or whatever. But you guys mostly use fentanyl anyway, right? So we don't have to necessarily worry about that.
I got a question on that.
Yeah.
So ketamine, since it's going to be more hemodynamically stable, I remember, I think it was fentanyl, talking about for internal bleeding. That might not be kind of best usage for that. I'd have to look again. But is there anything wrong with ketamine?
So fentanyl generally does not have as much of a hypotensive effect as your other narcotics. In general, it's the best narcotic that we use. Ketamine, maybe with more experience, ketamine will become more commonly used. But ketamine very quickly is going to become an abuse medication by our patient population if it's being used as a pain medication. We know. We have those patients that are regulars for migraines, and whether or not they're legit migraines or not, that some patients come in because certain doctors give them Dilaudid for their migraines. I don't give narcotics for migraines at all. It's just, I refuse to do it. One, because I don't want to, create that crutch for patients, and two, narcotics have a severe rebound effect for true migraines. So people that are actually having real migraines generally don't like narcotics because they know that the rebound headache is going to be worse. But I know that there is a huge subset of the population, or the migraine population, that now comes in demanding ketamine because there are certain docs that have started giving ketamine for migraines, and they give ketamine for all migraines, and you still get a high. I mean, ketamine is Special K, right? It's an abused street drug just as much as, well, I shouldn't say just as much as narcotics. Narcotics are a lot more popular, cheaper, but it still gives you a high and has a huge propensity for abuse. So I guess the quick answer to that is I would avoid giving ketamine as a regular pain medication.
Two questions. Is ketamine more available? Because like Spokane County, we're just kidding. Union County's been carrying it for a while now.
Right. Now, but do they actually use it all that much?
Right, and is that more of a pre-hospital setting, or are they actually like prescribing ketamine to for pain management
No.
patients outside the hospital?
No. Ketamine's not prescribed. There are ketamine clinics, and that's popular in other states. And that ketamine has shown efficacy in, a lot of mental disease, depression, and all of that. It's also shown efficacy in migraines, and that's why it's sometimes used. The problem is that if you start giving ketamine as a pure analgesic and not as it's intended, the ketamine clinic patient only comes in every 3 months for their migraine injection of ketamine. But the patients that abuse ketamine and shop ERs will come in weekly for their ketamine shot, So it's not commonly used right now.
And then going back to what Trevor was talking about a little bit, like on our drug profiles, we learned that fentanyl has like one of the precautions type of thing.
Hypotension?
Yeah. But then I've talked to a lot of people who have actually used it in the field, and they're like, as long as you got a line in place, go for it. Like,
For fentanyl?
don't worry about the hypotension.
Right.
It doesn't have that much of effect.
That's
And
true.
From the classroom standpoint, or
Right.
our drug profile standpoint, it's like, ooh, you just gave them fentanyl, and you just like take them because they're slightly hypotensive.
No,
So-
fentanyl,
118, oh, you got now.
fentanyl does not have that much of a blood pressure effect. It doesn't, bottom patients out with hypertension. If they're hanging on by a thread, maybe. And not even necessarily because the fentanyl itself caused any kind of vasodilation and decreased blood pressure, but simply because it did its job in treating the pain, and now that patient does not have that sympathetic drive creating this vasoconstriction on their blood vessels, and they're not controlling their blood pressure as much anymore because they don't feel that stress and that pain anymore. So if they're kind of right on the verge anyway, and then you relieve their pain, sometimes you keep patients in pain to save their life. Sorry, Does that make sense?
Yeah.
All right. So this kind of goes along with the donut analogy, but GI tract, if you think of it as kind of one long tube, and then it's just divided in different structures. And then you've got a lot of organs that are in junction with that tube and moving enzymes in and out. Let's see. So upper GI tract, mouth, esophagus, stomach, duodenum. This is the first part of the duodenum is the first part of the small intestine. So you've got physical digestion through a lot of this stuff in the duodenum. You start to get your chemical digestion. Also in the stomach, you have some chemical digestion. Lower GI tract is where you get absorption of nutrients, water, all of that. stuff. So upper GI bleeding is anything above the ligament of Treitz. Ligament of Treitz is right at the duodenum. So anything from the two first portions of the duodenum up is upper GI. Anything below that is lower GI. So your nervousness or your anxiety with GI bleed should certainly increase with the patient's age. And depending certainly on what medications they're on. A cirrhotic patient that has GI bleeding, that's a butthole puckering situation.
What kind of patient?
A cirrhotic patient, somebody with cirrhosis of the liver. So cirrhosis of the liver, so they've got jaundice, yellow skin, right? They've got ascites, chronic alcoholics. If they come in with any kind of GI bleed, doesn't even matter what it is, especially upper GI bleed, but lower GI bleeds as well, then those are scary situations. One, because you know that they have terrible portal hypertension. They've got terrible portal hypertension causing this ascites because there's such bad pressure backing out that it's pushing fluid into the free spaces, and you've got all this fluid in their abdomen. It's also causing this backup of all of their veins, right? So that means they've got dilation of the veins around their esophagus, they got dilation of the veins around all their intestines, everything else. And those things burst and start bleeding. It's really difficult to stop that bleeding. Two, that cirrhosis patient has liver disease. Where do a lot of your cofactors get made? That's responsible for coagulation in the liver, right? So you're not making cofactors anymore. It's like being on too much Coumadin, right? INR patients and bad cirrhosis patient, INR numbers in bad cirrhosis patients can be 3, 4, 5, really bad because they just don't have the cofactors to control their bleeding. So one, they have dilated vessels. Two, they can't clot it, so they start bleeding. You're in a shit show. Peptic ulcer disease, 6 major causes of upper GI. This is peptic ulcer disease. Peptic means duodenum. That means your ulcers in the duodenum. Gastritis, that's just inflammation of that gastric lining. Can also include gastric ulcer. Variceal rupture, and that's what I was talking about. The varices are those veins, the blood vessels around the lower esophagus that become dilated in cirrhotic patients, and if cirrhotic patients vomiting blood, you're in trouble because that variceal rupture is hard to control. Mallory-Weiss tear, those are a lot more common, and patients often will freak out about it. I vomited, and then every time I vomited after that, I can see blood in my vomit. Am I going to die? And basically, if you vomit hard enough, you get enough stretching of the esophagus, you create these micro tears in your esophagus, right? And they kind of ooze a little bit, but it's usually self-contained. You don't have to worry about those. It's when they have Borje's syndrome, where they actually tore through multiple layers of the esophagus, and then you're in big trouble. Mallory-Weiss, usually not. Esophagitis, duodenitis, they're all just inflammatory processes. Upper GI bleed, again, so puking blood is hematemesis, whether it's red or dark, right? Pooping blood is either hematochezia or melena. Hematochezia is red blood from the rectum. Melena is black blood from the rectum, right? Hematochezia is new blood. Melena is old blood. It's all blood that has been kind of broken down a little bit in the GI tract and turned black. Oftentimes, blood from upper GI, it has that coffee ground appearance because the acidity of the stomach turns red blood black really quick. What's that? Hematochezia. So hemato and then Chezia. That's bright red blood from from the rectum. All right. And some patients can vomit large amounts of blood. I mean, what's the fear of somebody that's vomiting lots of blood? Besides the obvious blood loss. That goes along with the varices. What are you worried about when you've got a guy or gal that's vomiting lots of blood? Airway, right? That should be like your first concern, because you can't stop that bleeding, especially in the pre-hospital setting. You can't stop that bleeding, right? That patient is going to continue to vomit blood. You can give them as much Zofran as you want. They're still going to vomit the blood because blood's irritating. It's going to come back up. And even if you do stop them from vomiting blood, but they're going to keep bleeding, right? So you're not going to stop that bleeding. They're starting to become pale. They're vomiting lots of blood. Your first concern should be like, when this patient needs it, and I have to assume that they're going to soon by the way that they're looking, how am I going to successfully establish an airway with all of this blood that they're throwing up? Blood's also very caustic to the lungs. You get a lot of aspirating a bunch of blood into the lungs. You get pleural edema, flash.
So can we talk RSI in that patient?
Yeah.
Because, I mean, that would be a concern if you start to push meds, is that they aspirate on you.
Make sure you have your suction. And yeah, RSI. Do it quick. Don't wait 3 minutes for pre-oxygenation, because you don't want a whole bunch of blood in your airway, right?
And G2 suction.
No, not necessarily for airway management, because I mean you can do a G-tube, but what's the problem with a G-tube in a cirrhotic patient that's vomiting a ton of blood? Right, you're making their varices worse. So yeah, you don't stick a G-tube down a patient like that. But from an airway perspective, you just need to have your suction ready and going when you're trying to do all this. All right, so general complaints. You know, you get this malaise, or I've just been tired and weak. That's common with your ulcer type patients that just have been slowly bleeding. They come in and they're anemic, with hemoglobin of like 8, but they've been having issues on and off for months. So it's just been this slow, ongoing process. Sometimes it can be a lot quicker than that, but weakness, they syncopal. You got a GI patient, upper or lower, and they're feeling dizzy. Every time I stand up, I get dizzy. Feel like I'm going to pass out. They originally called you because of syncope, and you go into their history, you start asking them more questions, and they don't even think to tell you about any kind of black stools, but you being the wonderful paramedic that you are, asking a good history, talk about black tarry stools. Oh yeah, I've had a couple of black tarry stools. I just thought there was something that I ate. That patient's hemoglobin's in the tank, and they're on the desk door and they don't even know it. All right. So treatment in pre-hospital setting, airway, right? ABCs first. Oxygenation, try to maintain their circulatory status. This left lateral recumbent, or this semi-Fowler's position. I don't even know what semi-Fowler's position is, actually. Does anybody here know what that is?
It's partially sitting up.
Partially sitting up?
Yeah, like
So
Fowler.
it's just incline?
Fowler's sitting all the way up. Fowler's like a 45.
So this guy Fowler just decided that
Yeah.
45 degree
Doctors don't name it.
just wasn't good enough. So I've always just called that, can you put the patient at 45? But
Now you're gonna look good on your.
now if I say Fowler's, then they're just going to be, what the hell are you talking about? But they're not going to, they're not even going to say that. They're just not going to do it. And then when I come in and be like, why didn't you put him in Fowler's? And be like, I didn't know what you're talking about. When we should have just said 45. Everybody knows what that is, right? So, where was I? 2 large bores. Got any kind of GI bleed. 2 large bores, right? Usually, if really any ER doc has a patient that comes in with more than 2 black tarry stools or any kind of history of copious bleeding, top or bottom, it's an automatic ordering 6 units of blood, regardless of whether or not we truly think that we're going to need it or not, because it takes time for blood to come, right? If you need it right away, patient looks anemic on exam, you don't want to wait for a CBC. You can certainly give them trauma blood, but in these patients, we order blood right away when they come in, because even if they look great, their vital signs look really good, it doesn't take long for them to hit that tipping point. When they hit that tipping point, you're already behind the 8 ball, right? Although with GI bleeds, that's where they initially started the whole theory and research, and started statistics on permissive hypotension, because with GI bleeders. Because if you throw a whole bunch of IV fluid or even a whole bunch of IV fluid and packed red blood cells on a GI bleeder, that makes their bleeding worse, right? You're diluting all of their cofactors. So, esophageal varices, it's a high mortality rate, right? So those should cause you to pucker a little bit. But you know what's interesting is these patients still don't stop drinking. Addiction, man. So alcoholic liver is most of your varices cases. They usually initially have painless bleeding because it's the vomiting, it's the Mallory-Weiss tears that cause pain, right? It's the tearing of the esophagus that cause pain. The esophageal variceal bleeds don't cause pain, painless, and they're oftentimes unstable hemodynamically. So you want to focus on aggressive airway management, getting ahead of it before you are in a situation that you're rushing to do it while they're hypoxic, and rapid transport, right? So top priority, airway. Suction is obviously something that you want to be thinking about right away. Where's my suction? Get my suction ready. High concentration oxygen. You guys obviously don't have octreotide. It's the only medication that really shows any kind of efficacy with variceal bleeding. It is a hormone modulator, so it works on the hormones, basically decreases that portal hypertension, decreases the pressure on those varices. So you guys can kind of see how that blood work works. This is all of the vasculature around the esophagus. If you get pressure back up, it causes these vessels to dilate to the point where their layers are weak, and it doesn't take a whole lot for them to bleed. This is like the catch-all for abdominal pain, right? Gastroenteritis. If you got vomiting and diarrhea, it's gastroenteritis. But what gastroenteritis is inflammation. Inflammation could be caused by hemorrhage, could be caused by erosion of that mucosal layer, infection, inflammation in general. So volume replacement, minimize hypovolemia, and obviously shock. And then think about this with individuals who abuse alcohol and tobacco. They are at higher risk. So for people that have GERD, peptic ulcers, gastric ulcers. You know, your big causes are smoking, alcohol, caffeine. All right. Why do you think caffeine is a cause of GERD?
Comes in coffee.
Not necessarily hypertension, but along the same road. What kind of drive is it from the central nervous system? Sympathetic drive. So if you're down in multiple cups of coffee a day or multiple Red Bulls or, you know, whatever, you're in this constant sympathetic drive. And it really does wreak havoc on your stomach lining and your kidneys, by the way. Stop doing that, Craig.
He takes other medications, so it's like,
Not to mention all the other crap that's in there besides the caffeine. Just stay away from it. Right. So obviously there's acute and chronic gastroenteritis. Acute is the rapid onset. You have to worry about dehydration, especially if they have quite a bit of diarrhea and they're not able to replace that. And I've certainly seen hemodynamically unstable patients just from gastroenteritis. Treatment is supportive and palliative, meaning trying to make them feel better. Pain medications. I usually stay away from pain medications in general with this, unless I know that there's specific pathology going on. But certainly antiemetics on board to try to get them feeling better. Then your chronic gastroenteritis can be caused by a lot of different things, but more common in the underdeveloped countries where it's infection based. You get a lot of similar symptoms, but it's chronic. H. pylori. Anybody know what H. pylori is? So this can be a cause of GERD. That's certainly not self-induced. It's a bacteria that causes increased acid production of the stomach. And so you get, patients can be on Pepcid or Prevacid or any of those medications and be like, it's just not working. I continue to have ulcers, continue whatever. It's because they have a bacteria that's wreaking havoc and they have to be treated with, and it's not an easy bacteria to treat. And from an antibiotic standpoint, they have to be on 3 different antibiotics for quite a long time before they're adequately treated. So next time you have a GERD patient, keep that in mind if you don't have your gloves on. Make sure that you're taking proper precautions, right? Your PPEs. All right, a couple more slides and then we'll take a break before we finish up the rest of it. So peptic ulcer, this is in the duodenum. This is erosion from gastric acid. Usually the proximal portion of the duodenum, males more than females. It can be genetic, so family history is useful with these kind of patients. But even important with family history, even if it's not genetic, it's environmental, right? The same things causing your dad to have this disease are causing you to have this disease because you're doing the same things your dad did. So it's more environmental even sometimes than genetic. So non-steroidal anti-inflammatory medications, it's another one for GERD. It's, ibuprofen and aspirins. And certain, acid-stimulating products like alcohol, like nicotine, and then the Helicobacter pylori, the H. pylori bacteria. In the pre-hospital setting, you guys have antacids, right? Do you not have Pepcid? No. I guess in some places they do. Peptic ulcers can also be caused by blocked ducts. Duodenal ulcers, this is what I was talking about before, the Zollinger-Ellison syndrome. It's a genetic abnormality where their cells are overactive, so they have too much uncontrolled acid production in their stomach, and they have constant problems with it. And then you've also had acid-secreting tumors. Chronic ulcers can be slow bleeds, anemia. Patient's concern is, syncope, but it's because they're anemic from their slow bleeding ulcer. But you can also have very dangerous ulcers that have an acute rupture and have acute problems. Nausea, vomiting, certainly massive hemorrhage can occur with ulcers. Patients can be very, very ill, unstable. Treatment obviously depends on how bad it is. All right, let's take a break right there before we go into the lower GI. Come back in 5 minutes. Not forget to do that. All right, so lower GI bleeds. Anything below the ligament of Treitz, again, would be considered a lower GI bleed, but mostly, lower GI bleed is past the duodenum, right? If it's duodenum and up, that's an upper GI bleed. If it's below that, it's lower GI bleed. Some of your main causes of bleeding or lower GI bleeds is diverticulosis. Understand what diverticulosis is? Do you know what diverticulosis is? So,
Does everybody have diverticulitis?
no. You develop diverticuli over time, depending on your diet, your lifestyle, and your age. But if you can imagine, again, your donut hole, right? This is your GI tract. If you can imagine, your lower GI tract is your large intestine, the large intestine part of that big long tube. A diverticuli, it would be what I would call like a bleb of that. It's like a bleb of your large intestine tissue. It's kind of like a hernia of your small intestine, but it's an outpatching or an pouching of your GI tract, and obviously it's a breakdown of those layers and of those tissues, and that's why it's pouching or pushing through and creating this ballooning effect, and they can bleed. They can cause, because they'll cause irritation, they'll cause breakdown of some of that lining around the blood vessels that's feeding that area of the intestine. They can cause bleeding. It's usually painless bleeding, but then you can get diverticulitis. That's when these get infected. They get bacteria that gets trapped inside those pouches. They get infected. They get inflamed. That's diverticulitis. All right. And that happens mostly in the distal part of the large intestine. That's why diverticulitis is mostly pain on the left side. So other causes of bleeding: colon lesions, rectal lesions, anal fissures, inflammatory bowel disorders, which include ulcerative colitis and Crohn's disease. Symptoms: it depends on where the bleeding is coming from, but often it can cause cramping, nausea, vomiting, and then obviously changes in your stool. Most patients don't have significant amounts of blood, and they are hemodynamically stable, but certainly you can have your unstable patients. Management obviously depends on how stable they are. Watch your airway and your oxygenation status. So ulcerative colitis, this is one of your forms of IBD or inflammatory bowel disease. It says unknown origin, but unknown origin as in we don't know why our immune system sometimes suddenly starts to attack itself. But ulcerative colitis and Crohn's disease are immunologic diseases. They're a problem with your immune system attacking itself. But most of the more recent literature shows that likely it's viral origin, meaning viruses carry all sorts of genetic code in them, right? And even though a virus might cause a certain illness or whatever, they're also sharing genetic code, and sometimes that genetic code can get placed in your genetic code and or signal your immune system. Even though your body gets rid of the virus, the effects of that virus stay, and you can have this immune response and later develop ulcerative colitis, Crohn's disease. But so most of ulcerative colitis involves the rectum and the rectosigmoid, and it usually spreads from the rectum up, but it is pretty localized in the large intestine. Pancolitis is when it involves the entire colon. It usually is rectum and left colon, your descending colon, but sometimes it can get bad enough that it involves the whole colon. So contributing factors, for the most part, the major contributing factor is this immunologic ulcerative colitis, but it's become kind of an umbrella term where inflammation of your colon can be termed just ulcerative colitis, and that can be caused by a lot of different things. Let's see, so ulcerative colitis is a little bit different than Crohn's disease in that it can create this bloody diarrhea, whereas Crohn's disease doesn't usually cause bleeding. But you get kind of this cramping, you get very mucousy stool, and then you can get bloody stool as well. Significant hemorrhage, I would say, I mean, at least in my experience, significant hemorrhage is uncommon with ulcerative colitis. It can happen, but of the hundreds of patients I've seen with ulcerative colitis, any significant hemorrhage would be like 5%. So I don't know how common what they're referring to. But anybody with ulcerative colitis that has significant pain, obviously you want to transport quickly. If they know that they already have ulcerative colitis, it doesn't necessarily always have to cause bleeding. I would say even more common than hemorrhage with ulcerative colitis would be perforation. You get such bad inflammation that actually perforates through, and then you've got bacteria into your abdominal cavity. And bacteria in the abdominal cavity is bad. That can lead to a lot of bad things. Hard to clean out. Antibiotics don't get to it very easily. That bacteria hangs out and chills. You have to open them up and do a complete washout of the internal cavity, and it's a mess when you get perforations that are not self-contained. So they're ulcers, right? So they look very similar to like your peptic ulcers and things like that. Crohn's disease. This is the other side of the inflammatory bowel disease. This can run in families in that certain, genetic families have a propensity to develop these immunological diseases. But the big difference between Crohn's disease and ulcerative colitis is usually localized. Well, it's always localized to large intestine, but it's usually rectum up, but doesn't go into the small intestine, nowhere else in the GI tract. Crohn's disease can be anywhere from mouth to anus. So they could have ulcerations on their tongue, in their mouth, and then also be having, cramping, abdominal pain, and it's called skip lesions, meaning that it'll affect here and then here and then here, and it kind of skips around. It's common to develop obstruction, intestinal obstruction. You get inflammation, you get these lesions, and because those lesions create scar tissue in in the GI tract has a high propensity for obstructions. That's why these patients that have had multiple abdominal surgeries are always having obstructions. They're always having abdominal pain. And it's mostly scar tissue related. People with chronic abdominal pain that have had multiple surgeries will continue to have chronic abdominal pain because of all the scar tissue. Because peristalsis, that contracting or uncontracting of your small intestines, creates this need for movement in your GI tract, meaning that, you push your hand inside your belly, that doesn't hurt, right? Your intestines can kind of move around and form, and they're not rigid. As soon as you get scar tissue in your GI tract, that becomes rigid. You don't have that free peristalsis. Every time it does peristalsis, it pulls and creates this stretch of that scar tissue, and that's painful. That creates this chronic abdominal pain problem. So, you get those patients that come in and they're like, I've been seen 100 times, I've had all of these surgeries, and I continue to have this abdominal pain, and I have no idea why. But they don't accept the answer of scar tissue. Sorry, you have extensive scar tissue in your abdomen, either because of disease, usually because of disease and because of surgery, and you're always going to have pain. There's nothing we can do about it. Another surgery is just going to make the problem worse. So flare-ups is usually pretty quick. They get, Crohn's flare or UC flare, ulcerative colitis flare. But you have to be careful. Sometimes these patients obviously become opioid dependent, just like other disease types. They have pain on a regular basis. They get a lot of pain medications, and they become dependent on those pain medications. Then they come into the hospital, regardless of whether or not they actually have any kind of flare. We get lab tests, and they're stone cold normal, get another CT scan. They've already had 30 of them, and that is normal again. And by that time, they're okay because they already got their, regimen of narcotics. But diverticulitis, that's the inflammation of this pouch again. It's the most common complication of the diverticulosis. Diverticulosis, again, is the bleeding alone. Diverticulitis is the infection of that pouch. Secondary to infection, usually left-sided. You have a fever involved with it because it's infection-induced. Usually you have an increased white blood cell count. They're nauseated, they're vomiting. Anytime you have inflammation in the intestines, it usually inhibits peristalsis. You get kind of this hold on digestion in general. You get bloating, cramping, pain. From the pre-hospital setting, it's supportive measures, right? Hemorrhoids, this is swollen veins in the anus. Same thing. You can get hemorrhoids from portal hypertension, just like you can get esophageal varices from portal hypertension. But the rectum, you can also get very significant hemorrhoids from other situations, like pregnancy, like sitting on the toilet and straining on a regular basis for too long. People that ride bikes frequently and too often can get hemorrhoids because of the pressure from the bicycle seat consistently. This is a little example of the dilated veins. These are internal hemorrhoids. Internal hemorrhoids is painless. External hemorrhoids are painful because of the nerve endings. So internal hemorrhoids, you get this kind of mucousy bleeding during defecation, especially if you have any kind of straining. External hemorrhoids, you can get bleeding anytime, but it can also be during straining. Also lifting, you get this increased pressure in the abdomen. And obviously hemorrhoids, that's bleeding really close to the rectum, so it's not going to be black stool, right? Hemorrhoids are going to be that bright red blood. You certainly can get significant bleeding, although it's less common. You definitely want to worry about it in the chronic alcoholic patient. Rectal foreign bodies. Favorite part, right? Reminds me of the Seinfeld episode. You guys remember that Seinfeld episode? Fusilli Jerry? Where Kramer made a Jerry out of pasta. It was the corkscrew pasta. He called it Fusilli Jerry, and then George's dad sat down on it. 1 in a million shot, dog. Honestly, we don't even hear that anymore. We hear it from some populations, but most of the people that come in with foreign bodies have no shame. I'll just tell you all about it. It's either they'll tell you all about it and they don't care at all, or they have no idea when it happened because they were so drugged out and doped up and whatever.
I slipped and fell in the shower.
Right. But so I've seen a lot of different foreign bodies in my day. Probably the largest one was a 32-ounce coffee mate bottle that was jammed up, and it was all the way up at the splenic fissure. So it was like, I mean, it was touching the splenic fissure, or the splenic fissure where that the descending and the transverse colon meet. It was way up there. No, he was having this gentleman was having a drug-induced orgy, and they were trying different things. And his wife or his friend's wife, he can't remember whom, but he was sure to tell me that it definitely wasn't his friend. One of the two women had continued to jam the thing up there.
Not my friend, I swear.
It wasn't his friend. I swear it wasn't my friend. I've seen, that was the biggest one. I've seen pool balls. I've seen light bulbs. Obviously, a lot of different vibrators. What's that? Yeah, light bulbs.
What if they shattered?
Dumb, right? Oh, we've had that happen before. Yeah.
So,
Surgery, lost a few segments of their colon.
so is that where you go in and you surgically remove it, or you pull it out?
Depends. If it's too far up there, then yeah, surgery. They have to. Well, they don't necessarily. They don't have to open up their abdomen or anything. Most of the time, they just have to put the patient under anesthesia, general anesthesia, and use some different tools to get that thing out. Because oftentimes, the problem is that it creates a negative pressure behind it. So you try to pull on it, like the patient, and they're like, I tried to get this out 100 times and I can't do it because it's stuck. It's stuck because of that negative pressure. So there's, every time they pull, it creates this negative pressure behind. So you have to, if you can see it, and if it's not too far up there, you have to snake like a Foley catheter back behind it and inflate it so that you equalize that negative pressure, and then it comes out fairly easily. Because these patients that have these huge foreign bodies, it's not like they have a whole lot of sphincter tone. So it comes out easy once you get rid of that negative pressure.
Well, they got a pretty high chance of rectal prolapse, right?
Yeah. But did I tell you guys the story of the vibrator in the waiting room?
Nope, no, let's hear it.
Okay. So I guess I got two stories. One, I had a younger female that came in because she thought that she had a vibrator stuck in her vagina. Turns out it wasn't in her vagina; it was in her rectum. But that one was a funnier story because she couldn't remember it being placed, and I don't know why she would have thought it was in her vagina, and her not being able to tell because it wasn't a small vibrator. But I think that's just what she told me to save the embarrassment of telling me that her boyfriend had stuck it up her butt. But she, one, really wanted a female doctor, and two, apparently didn't like my youth. or my youthly appearance. Because when I walked in the room, she was like, "You gotta be kidding me! You're my doctor! Like, get out!" She was mad that I was her doctor because she didn't want to tell me the story, apparently. But then when it was in her butt, she was like, I think all of her shame had left, and she was like, "I don't even remember, whatever." I kind of figured it was in my butt, but anyway, the second story was that we had this guy that had a vibrator in his butt, and he couldn't get it back out because of this negative pressure effect. He couldn't get it back out at home, so he came in, but the vibrator was on. And so, he sits down in the chair, and the chair has metal legs, and the floor is a tile floor, so it was just like loud. It's like an amplifier, right? It's just like. And so the nurse comes out to me, and she's like, "Dr. Raby, you are not going to believe this. The guy has a vibrator, and it's still on, and everybody can hear it." And I'd be like, "Okay, I want you to go out there, and I want you to make an announcement that whoever has their phone on needs to turn it on." It was awesome. Yeah, she totally did it. And she did it with a straight face. I had to do with a straight face, because if she started laughing, then obviously we both would have gotten along. So, but she did it with a straight face, and it was pretty awesome. That was one that we had to put the Foley up there, and actually the vibration helped get the Foley up in the right place, because it kind of snaked right up there.
Did you give him the Foley so he didn't come back?
Yeah. Here, keep this. Next time, just
Do it yourself.
No, that's probably a bad idea. They probably try to use the Foley for something else. He kept his vibrator, yes. The Coffee Mate bottle, I don't think he kept that one.
The same guy?
That one was awesome because on a CT scan you could just see that hourglass, bottle. It was just like, seriously? But because he had no idea what was up there either. He just couldn't poop for a week.
Oh, so he took his time.
Oh yeah. He had no idea that anything was in there. He came in. He's like, "I have not been able to shit for a week." And he admitted everything. He was like, "Listen, sometimes I have these orgies, get together, we experiment. There could be something up there. I don't know. I don't remember it because I was completely wasted."
It wasn't his friend.
But yeah, he did remember that it wasn't his friend. Doesn't remember what it was, but he knows that his friend didn't put it there.
What it is, when it happened, but I do know it was not his friend.
Shit. Got his friend's name on the cover.
All right, so this segues into bowel obstruction. So this is the blockages of the donut hole, right? The lumen space. Can be partial or complete. Complete meaning that nothing's getting past it. There's no air past that obstruction. And partial is that you're getting something past it. This can be caused of hernias. If you have a groin hernia and you have loops of small bowel that's also herniating through, well, that loop of small bowel is going to get pinched off, creates an obstruction. It also cuts off the blood supply and it starts to die. And that is a surgical emergency. Intussusception. There's no what intussusception is. This isn't the movie, right? You guys have heard the term intussusception, right? Never?
I don't think so.
All right, so it's much more common in pediatric patients, but can happen in adults depending on what kind of pathology they have, sometimes with cancer. But you can imagine, like, you've got your normal intestine is just a tube, right? Kind of a smooth tube. It contracts and uncontracts. Well, intussusception is when it folds onto itself. So you get kind of this thing going, where it folds over onto itself. And that happens because this contraction and uncontraction, you've got all this smooth muscle contracting and uncontracting. If you've got like a cancer met or something like that, or scar tissue or something like that, when it contracts on top of that fixed portion and then pulls on it, it pulls itself over onto itself. When you get this overlapping, it also cuts off the blood supply, and that will die if it doesn't fix. Generally, we can fix these without surgery. We do an air enema, where we force air up their butt and kind of blow everything up. And as you dilate and blow everything up, it kind of unwrinkles and unfolds. That's intussusception. Volvulus, you guys heard the term volvulus? That's twisting on itself, right? That usually happens because the same thing. If you got scar tissue or some kind of fixed point, and as it's, as your intestines are moving around or whatever, something causes it to twist at that point, and it creates an obstruction. Again, affects the blood supply, and then adhesions. Adhesions are scar tissue. Scar tissue is probably the most common cause of bowel obstruction. Scar tissue